All right, everyone. Thanks for joining this week's virtual global spine conference. Hope everyone is having a good week so far. I'm joined today by our fearless leader, Ali Baj, and other members of our team like Mike Algano and Alex Mamagani. And we're really honored to introduce this week Dr. Byron Stevens. Dr. Stevens is an orthopedic surgeon at Vanderbilt University, where he also serves as chief of the spine service. And I thought he had a really interesting topic for this week, which is avoiding three-column osteotomies in adult spinal deformity. Most of the sort of the heavy hitters like to go around and talk about how they, like to do those things, but I think fair amount of evidence suggests issues with complications and blood loss and whatnot. So we're all super excited to hear what Dr. Stevens has to say. And with that, I'll let you take it away, Byron.
Great. Thanks, Coy. Thanks, Ali, for inviting me. I appreciate the opportunity. Can everybody hear and see me okay?
Yes.
Great. So our topic for tonight is going to be avoiding three-column osteotomies in adult spinal deformity, and maybe perhaps what to do when you can't as well. As far as disclosures, we get some institutional funds from Stryker for research funding, but I don't have any other relevant disclosures. I think the biggest disclaimer I have, however, is that I really am a big believer that you should avoid a three-column osteotomy really whenever it's reasonably possible. And that the reason for that, I think, is well supported in the evidence. The best evidence we have in terms of prospective and retrospective analysis of these patients is that the complication rates are soberingly high, nearly an 80% complication rate, 60% major complication rate in multi-center studies that I would add are really the best surgeons out there and world-renowned experts treating this problem. So if there's a way perhaps to avoid three-column osteotomy, I think it behooves us to do so. This will do mostly cases, and I'm going to try to make this as interactive as possible, and really want to sort of pick the brains of the people that are on here tonight. And this first case is a 77-year-old female who comes to us with a progressive deformity, primary complaint of low back pain, perhaps also some radicular pain in the concavity of her lumbosacral curve, T-score minus 1.6. And you see here, she has this large apex left thoracolumbar curve measuring 90 degrees, but it's a combined deformity. It's a combined coronal and sagittal deformity. She has severe sagittal malalignment. SVA is nearly 20 centimeters. Interestingly, relatively low pelvic tilt and a moderate pelvic incidence at 49 degrees. How I look at these is, we really want to assess flexibility in these curves. And I'll get supine imaging often. I'll also get CT scans. And for me, the CT scan is really clear, or really key rather, to determining where I can get correction, and the vacuum disc phenomenon that you see in sort of the apex of her curve here, I really view that as an opportunity for correction without the need for more invasive osteotomy. Sort of quick poll maybe of Coy, Alex, Mike, and Ali. T-score of minus 1.6. Who would give this patient Forteo? Who would not? What are your sort of indications? I'll tell you, for me, I'm sort of fortunate to work with some really great endocrinologists who are able to very easily get these patients approved for Forteo. I'm not sure exactly how they do it, but I've moved to even osteopenia, even patients with osteopenia, getting them on Forteo. Coy? What are you guys doing?
Yeah,
to do?
that's interesting. Sorry for my baby in the background. Um, that's actually really fortunate you have that opportunity. I guess for Forteo or Timlos, I've been treating true osteoporotic patients. So minus 2.5 and worse. Although if it gets close to that, definitely we'll try to get them treated as well. I do typically send to endocrinology. I guess for a minus 1.6. Generally have not, but I would make sure that they're on at least calcium and vitamin D, for their osteopenia. But in my practice, at least, would not be starting these patients on Forteo yet. But Mike and Ali.
Yeah, I agree, Clay. I have a pretty similar practice too. I think another issue that I see Ali brought up is getting insurance approval. I think that's one big issue at Forteo. The other issue is getting serial DEXA scans if we need to. If a patient's had a DEXA scan within the last year, sometimes we can't really repeat it. That's kind of been an issue in my practice too. And we don't really have the luxury of a very robust endocrinology department, to the point where I've actually considered even prescribing Forteo myself and getting all of the parathyroid hormone labs and things along those lines. So to answer your question, for osteopenia, I probably would not treat it. I'm negative 2.5 and below, like Coy said.
Great. I think it's a fair point, right? There's not a lot of evidence to guide us here. I've just been so impressed with Forteo and its ability to prevent, at least knock on wood so far, PJK, PJF in my patients. I really will try to get them on it, even if they're not traditionally indicated for it.
Byron,
yeah.
How long before surgery how long will you treat patients before undergoing on the knife? And do you just go, or do you do some sort of confirmatory DEXA or CT to check the Helms field or anything like that?
Great questions that we don't know the answer to, I think. For me, people with osteopenia, I sort of look at it as a bonus. Osteoporosis, I guess my answer is as long as possible. We have not, the endocrinologists that we work with here do not sort of recheck regular T-scores. And I don't know, they question the validity of that. Do you guys have any hard cutoffs where, let's say, a patient with osteoporosis starts anabolic treatment where you won't operate on them? Or, for me, I'll say a person with bad osteoporosis, say a T-score -3, I'll try to limp them along for as long as I can, sometimes 2 years of this treatment. But I've found that the T-scores seem to really lag behind. I do use Hounsfield units, but I don't have specific cutoffs, and I'd be curious if others in the group do.
Yeah, my practice is basically just copycatted from those around me, but essentially, pre-treatment for at least 3 months, longer if at all possible, and then continued treatment after surgery, but no real sort of confirmatory study prior to undergoing the knife. Ali or Mike?
Yeah, Byron, that's a really, really nice first case to kind of kick off the session. And I think, starting off with a discussion on osteopenia and osteoporosis is really critical for these patients. And I'll tell you what I've learned over the last, say, few years is, if you're lucky enough to be in an institution or in a multidisciplinary, spine center, and you really have endocrinologists who not only obviously understand the osteoporosis, kind of bone metabolism issue, but really how it's clinically pragmatic or not, right? Because there's a way that they look at it and there's the way we look at it. And I've kind of learned this from some of my ortho colleagues that, to use the cliche, own the bone, right? I think I'm more in line with having my own kind of, say, protocol or standards based on literature, based on what most of us, say, neurosurgeons and orthospine surgeons do, and then find an endocrinology colleague who will be able to kind of implement that algorithm together. But I found that if it's just an algorithm or a protocol that's completely, say, endocrinologically based and independent of our input, that tends to not be as successful. So that's my that's a long way of saying that I think it's good for us as surgeons to have our protocol, have our algorithm, and basically have endocrinology help us, or team members help us implement it. rather than just say, hey, this patient has osteoporosis, please treat and send them back to us. Does that make sense? Do you know what I'm trying to say, Byron?
Yeah, for sure. I mean, I think a partner is key, and I definitely I feel very fortunate to have the partners we do here in endocrinology, essentially who get it. I will send them patients, and I found often without before developing these relationships and these connections, you would send a patient for anabolic treatment, and it seemed about 50% of the time they would actually get on Forteo or Tymlos, and then half the time they would end up on an older non-anabolic medication that in my experience that does not have anywhere near the same efficacy of the newer anabolic agents. So yeah, partnering with somebody and having a system down, I think, is key. So great discussion. So for me, looking at this curve, things I'm worried about preoperatively, number one, the spine is well balanced overall in the coronal plane, very poorly balanced in the sagittal plane. I'm worried about this patient's stiff lumbosacral fractional curve, and my ability to correct that, and also my ability to correct and restore sagittal alignment. However, I don't, see a sort of need for any high-grade VCR or PSO in this type of case, and really the workhorse of correction in this type of deformity for me is multi-level posterior column osteotomies, and I really favor ALIF in the setting of a stiff lumbosacral fractional curve. I know based upon supine imaging or CT scans that I can correct the main curve in this case. You see the vacuum disc phenomenon on the CT scan, the correction on supine imaging. But what I'm worried about correcting is, or not correcting, is the stiff lumbosacral fractional curve. And so this is a case where I think ALIF is the answer for me in terms of correcting that curve. And that's what we did to start. I stage these cases by 2 or 3 days. And essentially what I want to do is level L4 and make L4 horizontal again through ALIF. And then really the rest, it makes the rest of the surgery and the correction a lot easier. You see, we ended up with a well-balanced curve here, nice correction, and a good clinical result. Any comments? Ali, would you do this differently, or Coy or Alex, Mike?
Yeah, that's awesome. Obviously, that's an awesome technical result, Byron. I agree with you. When at all possible, stick to the PCOs and avoid the 3-column osteotomies. I do have a question for you. You brought up an excellent point about the fractional curve and how, as you obviously alluded to, is you can make the patients even more coronally imbalanced if you don't take that into consideration. But here's my question for you. Do you, in this particular case, did you feel that you had some correction of both, definitely the coronal, but did you have a correction of the sagittal imbalance after the ALIFs, or is the sagittal correction all with the PCOs? In other words, besides addressing the base and the fractional curve, what did the 4-5 and 5-1 ALIF get you in terms of the correction, not in terms of the arthrodesis potential at the bottom?
Yeah. Great question. I think yes, the ALIF definitely helps with correction of lordosis, particularly, down low where we know it's important to restore it. And yes, I think ALIF helps me there for that as well. It's not only the coronal lumbosacral fractional curve, but the sagittal correction as well. And I think too, in my practice, fusion. It's much easier for me to obtain a fusion with ALIF than TLIF. If I do an all posterior approach, I'm much more likely to have multiple rod constructs, 3 or sometimes 4 rods. But I feel pretty comfortable with ALIF and perhaps some off-label use of biologics, depending on what type of cage you use, to get a solid arthrodesis across the lumbosacral junction.
Byron, what's your strategy across sort of the the apex of the deformity? Just a posterior column to kind of loosen things up, or?
Yeah, we it's stepwise sort of, posterior column osteotomies. I start with, partial facetectomies, essentially, in the mid thoracic spine and down. So starting at, in this case, it would be somewhere around T6. And I do that for screw placement as well. It helps, I think, with accuracy of screw placement to see the superior articular facet, particularly in these heavily, these rotated cases, the curves with a lot of rotation. I find that very important to freehand screw placement. But in terms of correction, what I will do, I'll typically start when it comes to time to place the rod. I will place a temporary rod, usually actually in the convexity of the lumbosacral curve, and I can press on the convexity to generate more lordosis, but also horizontalize L3 or L4, depending on the curve. And then once that's done, so in this case, that would be on the right side, a temporary rod from L3 to either S1 or your pelvic screw. And then I place the left-sided rod in its entirety because I want to lock in lordosis first. And if you do the opposite, if you distract the concavity, you're actually going to lose lordosis. So I'll then place my primary rod, and in terms of essentially I just bend one plane into the rod, and then I will do a lot of in situ rod contouring and cantilever reduction to reduce the main curve.
Byron, do you ever have any issues with cantilever, rod reduction in these patients who are osteopenic? Like if you're using reduction screws, do you ever have issues where the screws start pulling out? What are kind of your strategies to help mitigate that?
Yeah. Yes, it happens for sure. I find it happens more with, extreme rotation. And when you're asking a lot of the screws, through reduction tabs, it's sort of translating the spine at the apical levels more posteriorly. And it's a feel thing for me. I mean, it's a feel thing knowing what their bone, the bone quality is as we're putting in the screws. And sort of, this is where I think experience is paramount, and sort of knowing what you can ask of the screws and what you cannot. I've definitely had it happen for sure. But I think, as you do more and more of these types of cases, you kind of get a feel for it. I don't know if you have any tips or tricks to share, but that's been my experience.
Yeah, I mean, I run into the same issues that I'm sure you guys do in some of these patients where, I've actually kind of gone back in time. I've gotten back to using reduction screws in some cases like this, but like you said, you definitely do have some screw pull out once in a while. So.
Yeah, I've kind of gone back and forth on reduction screws. I will use them for AIS cases, but I don't use them a lot in adult deformity cases as much because, particularly at the lumbosacral junction, you get this situation where your L5 and your S1 reduction tabs are crossing, and that's a major nuisance for me. And I think in osteoporotic bone, if you ask too much of the screw bone interface, it will fail. So,
Hey, Byron, we've got a number of questions from the chat box. The first one is whether you're concerned about the morbidity of an ALIF in a 77-year-old, and along those lines, do you have a age cutoff for ALIF?
I do not. I am. I think ALIF is powerful surgery. It comes at a cost. There is no doubt, and there is morbidity associated with it. I am very selective about patient selection. I think that's actually the most important thing in treatment of adult spinal deformity is appropriate patient selection and finding patients that can withstand this operation. And I would say there are 77-year-olds and there are 77-year-olds. I mean, I think that was illustrated nicely this year at SRS with Chris Ames's work and looking at things like telomere length and signs of physiologic age versus numerical age. So yes, I worry about it, but sometimes I think it's still the right answer. It's not a cookie cutter for me. I actually, if I feel that I can correct it from an all posterior approach, that's what I do. This happened to be a case where I felt like ALIF, the combination of its ability to correct both the sagittal plane deformity and the stiff lumbosacral fractional curve is why I chose ALIF in this case.
Hey Byron, it's great to see you. John Shin here. How are you?
Hey John.
Hey, great case. Hey, can you just comment a little bit on your experience with using interbodies above that L4-5 level? Like, do you throw in some TLIF cages, or, what about using supplemental rods across, the apex of that curve? If and when you use those techniques, as I've had some problems of rod fractures and failures, above the, where there basically was vacuum disc and where they weren't sort of supplemented with interbodies. And the question I always have is, how far do you go? And if you commit to that. So I don't know if you utilize that, or I don't know anyone on the panel here who does, but that's always been a question for me. It's just like, man, how many interbodies you're putting up? Because that all takes time to do, and morbidity. So.
Yeah, no, I agree. I think, for me, it's this balancing act. Yes, you're adding, stability with an interbody graft or cage and hopefully an interbody fusion. But you've got to take a lot of the spine apart to get to that point. And so those are sort of conflicting forces. I do enough interbody work to level the lumbosacral fractional curve. And if there's an area of severe stenosis, I will do a laminectomy and typically an interbody at that level as well. But I really believe in and rely on a good interlaminar fusion with BMP to achieve a solid arthrodesis. I have stayed away from multiple rods in the absence of, if I'm doing an ALIF and using BMP, I typically don't use these 4 or 3 rod constructs. I may regret that in a few years, and I agree that it's, rod fracture is something that continues to plague us as a profession, and I think that it's open for debate. I also, know that, anytime you put hardware anywhere in the human body, there's a race between one of two things happening. Either the fusion will heal, or the hardware will fail. And I believe with BMP on my side, I can win that race a lot of the time. But I contend that it's an unanswered question.
Hey, Byron, Matt Goodwin watched you. Just at one more comment. I know we're kind of getting stuck on one case, but it's a nice case. I love the construct. This is the answer for me also for this case and for my partners here a lot of times. 2 questions about it. Do you do anything? I also stage mine, and I have a date between. Do you do anything imaging-wise between them? Do you have them stand up and do a standing film, or do you do a CT or anything? And then I guess my second question is, and you might have said it, do you use a ProAxis bed on the second stage posterior part to dial it in or not?
Great questions, Matt. Good to see you, man. Yeah, so I get Scoli X-rays a lot of times. I don't think I got one on this case. I think I got just a lumbar flat plate because most of her deformity was at the thoracolumbar junction. but yeah, I do get a standing. I actually just get the lateral typically, because I don't know what information I gather from the AP, and it's a lot of work, and it's hard to get these patients to stand, after after that surgery sometimes. So, and then the ProAxis table, the answer is I use it every time I can, but it was brought to this institution by a colleague of mine who owns it essentially. So if he's using it, we don't get to use it. But yeah, I've moved more and more to using it, and I love that bed. That bed is incredible.
Yeah, it's great.
Yeah.
One more question, Byron, from the chat box, which is from Dr. Suresti. And again, I think this is great. I think every time you can spend the session or most of the session talking about one case, it's really good. But what was your screw strategy here in terms of uniaxial and polyaxial?
Yeah, great question. I use all polyaxial screws. I don't use any mono screws. It's just all polyaxial screws. And I would perhaps say that we could get better correction of the rotation, but in adult cases like this, I really worry about that. And I also don't know what the purpose of that correction of the rotation would be. All right, so we'll sort of move on to the next case. This is a younger patient, 54-year-old, very active, healthy, sort of executive type person who had a Harrington rod surgery done a long time ago by another surgeon here, and really did great for a long time, as all these people do, but developed sort of the classic Harrington picture of flat back deformity, and really presented with the classic flat back complaints of inability to stand up straight, sort of worsening sagittal balance as the day goes on. And came to me sort of thinking about options. I actually treated her non-operatively for, I think, a year or two. And then she finally just came back and said, I've had enough. So you can see she's got very high pelvic tilt, high SVA, relatively high pelvic incidence. And she's fused solidly to what the radiologist is calling the L5 level here. And I'm always impressed, like very, very impressed by our forefathers and their ability to get a arthrodesis in these obviously younger patients. It's just a solid block of bone. So sort of throwing this out there, things I think about, I want to avoid the 3-column osteotomy that I think some people might choose here. And again, I look at these open discs and unfused segments posteriorly as an opportunity for correction. However, in this case, I don't think there's any way to get the correction that you need without a 540 approach. And I know that's a lot of surgery and a lot of time in the operating room, but I would still say, at least in my hands, it's a better operation than a pedicle subtraction osteotomy in this case. So in this case, we went posteriorly first, did an aggressive grade 2 posterior column osteotomy at L4-5 and L5-S1. And this was a case, we did the 5-1 ALIF first, and we moved up to 4-5. And we were serially sort of trialing these implants and physically heard the spine sort of, give way, if you will. And, we're able to get a sort of tremendous correction, especially through the 4-5 level. And then posteriorly, it's essentially a chip shot in a day or two. We had some fun working around the fusion mass and the Harrington rod. And I debated some about where my upper instrument vertebra would be here, but I'll tell you, clinically, this was an absolute home run. You can see nice restoration of her lumbosacral deformity. And she's super happy. She hikes, sends me pictures every year of her hiking somewhere else with her daughter. So thoughts here, Coy, anybody doing a PSO in this case, or?
No, No, Byron, I think absolutely right to utilize the unfused segments to your advantage here, which I think you did really, really nicely. Can you talk a little bit about your instrumentation level selection? I guess why go above L4, L3, given that that's all fused already?
Yeah, I would agree. It's maybe not necessary. I thought I thought about keeping it shorter. I did want to cross her rod on the right side and sort of stop somewhere safe, whether it's 4 levels, 3 levels, above. I think is up for debate. Don't have a great answer for you or scientific rationale other than I wanted to get enough fixation to get her to heal.
Dr. Echt is asking a question in the chat box as to whether you have any concern for galvanic corrosion by leaving the rod in.
Yeah, great question. Yes, although maybe uncertain of the implications of that. A B, I would tell you that rod was under so much bone. The morbidity of removing it would far have exceeded, in my opinion, any benefit.
Hey, Byron, this is Ali. Again, really, really great case here. And I think it's very kind of creative what you did. I will say something, you bring up a great point here, which I think should be highlighted. I think we've all seen cases and we may have had some, I know I've had some of my own in which there was a previous posterior, say, long construct or old Harrington rod, and it seemed like a solid fusion, right? And then I don't know if this happened to you or not, but I've seen cases in which we remove the hardware and then fuse / instrument, the unfused segments and leave the old fused area without hardware. And we've seen some pretty disastrous fractures across those levels, which is mind-boggling because we think that, hey, they're fused, why are they fracturing? But to me, the learning point from this case is I think it's a really good idea to cross that, to overlap old with new hardware and don't leave any quote unquote naked levels with just, even if they appear to be ankylosed. I really do think that hardware on top of a previously fused area does confer added stability. Just my personal experience. I'm wondering what you and others think about that.
Yeah, I agree. I mean, it really is the principle of stress shielding, right? That bone is not normal if it's shielded by instrumentation. And yeah, I agree. I would share the same concern about taking it out. Haven't done it a lot, so I haven't seen any of it, but it's good to hear.
Yes, Ali, I agree completely. The bone is not the same as in an unfused bone or uninstrumented bone. And I've seen several disasters after implant removal, and even in ankylosing spondylitis, I would never recommend to take it out. And I love this images. Byron is awesome pictures. I understand why she's the happiest patient from you. This is awesome, really great.
All right. Next case. This is a younger patient as well that was in a motor vehicle accident long before I started practice. I think this was like 2009 or 2010. 54-year-old medical malpractice professional, and was treated by another surgeon with this construct initially. Had this pincer type L3 fracture. Somewhat unclear in terms of the indications for surgery. I didn't dig too much through the old medical record, but I did find these x-rays interesting. This is the immediate post-op in the, I think, PACU x-ray, which was promptly revised to this, which 1 week later looked like this, and then was subsequently revised to this. And many moons later, I met this patient with this x-ray. Interestingly, young, totally healthy, normal person. And I said, why is his bone doesn't look great to me, and why is he not sort of fused? And so we did a bone metabolism workup, and his T-score was -2.0. I put him on Forteo. I can't remember exactly how long. It was over 3 months. And then, of course, he sort of has the classic flat back deformity complaints. And I, at the time, this is pretty early in my practice, and I really shopped this case around and got the classic, show 10 spine surgeons one X-ray and get 12 different answers type of experience. But sort of looking at this, I thought about everything from a PSO to ALIF to back front back to I can't help you. You need to go somewhere else. Matt, I thought about sending him up to Mike Kelly at WashU. I actually think I did for another opinion just to sort of talk it through. He ultimately lives here and came back here. So in any event, this I think is a case where I think a PSO here is unequivocally, in my opinion, the wrong answer because this is not fused anywhere, and you're taking 6 unfused bones and then making them 7, right? You're cutting one of them in half and expecting that to biologically heal is, I think that's a tough sell in my opinion. So we started in the back, removed the screws, posterior column osteotomies, sort of ALIF. And I think this is a point for the residents, fellows, younger surgeons on this call. This is not your one level, sort of degen, ALIF, perk screw case. This is a case where you've really, if you want to get true intersegmental correction, you've got to really trial these, sequentially trial through the different sizes. To get, I think, true correction without in-plate subsidence. So that's a tip. I mean, it takes a while, but it's something that I think a little bit of more patience in these cases will pay off. So this is our.
So I apologize. I don't want to interrupt, but you bring up this point, and if you don't mind, just spend an extra minute or two and kind of teach us your technique of being able to get a hyperlordotic cage in front. Obviously, you obviously do it exceptionally well. Is the threshold or inflection point when do you resect the PLL? Do you go more lateral on the annulus? Are you waiting to hear that pop? What are the tricks? What are the technical pearls that you use to be able to get you from that 10, 12, 14 all the way up to 18 or 20 degrees or more? Can you just tell us a little bit more about the technique?
Yeah, great. Really, it's starting with a wide exposure, having a good access surgeon to get you that wide exposure, a wide sort of circumferential resection of the annulus, a very thorough discectomy, and the biggest mistake or problem that I will make sometimes or have sometimes is not being posterior enough with your disc resection. I get a very large curette in the far back nooks and crannies of that disc space and remove essentially all the way back to the posterior annulus. Obviously being careful if they've had a prior discectomy, but I think it's patience. It's a wide exposure, thorough discectomy, using larger implants, wider, so your mediums and larges, not your small footprints. And really,
so you take as much of the annulus, obviously not just what's kind of ventral, but you also go posterolateral and sometimes even cheat a little bit more laterally to take as much as much annulus laterally as possible.
Yeah, I won't get into the lateral annulus. I would say the anterior 2/3 of half to 2/3 of a clock face, really whatever I can get, to be honest. And I'll get a curved curette, and I won't take the annulus laterally where it's unprotected, but I will do a thorough discectomy to the annulus laterally.
Hey Byron, let's contrast with your previous case real quick. So that one was a 540. So I suspect that releasing the facets in the back really helped with the correction that you got from the ALIF itself. I think this one's just ALIF alone, right?
No, we started in the back with this one as well. You can see the broken screw, and so we started like this, and we started posteriorly and did a facetectomy as well. And I think that's key. I mean, I don't think we could have corrected. We probably could have gotten great correction through 5.1, obviously. And I don't think you have to do a 540. I'm certainly not advocating for that on every case. I know I've shown a lot of those, I guess. But certainly, if you don't have to go posteriorly first, you shouldn't. But in these cases, I felt like it was necessary. So, we essentially then came from the back, and I had a long discussion about him, about additional osteotomy work. And he is obviously very sort of keen on complications and complication avoidance. And ultimately, we accepted a little bit of undercorrection for his age. But I will tell you, he is also sort of extremely happy. One thing I'd like to point out, there are all sorts of ways, sort of measurements and new measurements coming up all the time in spinal deformity, and it's sort of easy to get lost and say, I know what works for me. And I'll admit, for a long time, I focused so much on the PI-LL mismatch, and I still do. I think it's important, but some measurement of angular deformity, pelvic angular deformity is important, I think, to incorporate. And this is from this year's SRS. One of our former residents, and Mike Kelly, presented this nice paper that sort of perhaps showed the utility and reproducibility of the L1 pelvic angle, which I find to be more clinically useful than TPA, because it's something that you can measure on a short flat plate X-ray, and it is heavily correlated to predicting your postoperative pelvic tilt, which is something, this case for me was frustrating at the time, because I was like, man, I got a pretty good correction, but his pelvic tilt is still high. And I sort of beat my head against the wall a little bit about that. And the reason is his L1 pelvic angle is not where it should be. So, not to belabor this equation, but it's something maybe to look at. And I know Jeff Hills and Mike are going to publish this. But your target L1 pelvic angle should be about half your pelvic incidence minus 21. So, Ali, Coy, are you guys using TPA, or what sort of measurements do you guys like to use?
I'm still mostly, SVA, PI, PT, LL. I haven't used TPA much yet in my practice, but would be interested in Ali and Mike and Alex.
Yeah, same. I'm with Coy, Byron. I still classically with the PI, LL, SVA. But do you mind showing that last X-ray? One thing that kind of came to mind that I think is important, is very pertinent to this discussion, right? So, if I looked, and I think you'd agree with me, right? If we looked at this X-ray and somebody said, hey, this is the post-op X-ray, and you're looking at that straight rod in the back, and you're looking at the trajectory of the UID screw, and you're like, oh boy, this is like a PJK waiting to happen, right? And I love that you're showing this 2-year post-op, and I think that's where you're absolutely right. You can't get bogged down too much with one number or one angle. It has to be, this process is so multifactorial. And when you said he's undercorrected, these are exactly the patients that, in my opinion, and certainly in my experience, if I quote unquote do that perfect correction, I probably will have a higher PJK, PJF rate. So sometimes undercorrection holds those patients just enough so that they decrease the chance of failing up top. And I think that's a really, underemphasized point. So this is a great X-ray 2 years and a really good teaching point here. Thank you.
Yeah, I would agree, Ali. I'll tell you, this, I think this is one of the first sort of bigger deformity cases I did. And I will admit, I under-contoured that upper aspect of that rod. And it's something that I really emphasize now. And I think we got away with one for sure, but totally agree. Upper rod contour is important, and prevention of PJK for sure. But sometimes, obviously, even you do that, you do everything right, you still get PJK. So that's being a deformity surgeon.
Hey, Byron, I have one final question to this. Did you follow up in the CAT scan what happened to this fusion, to this bone graft in L2 to 4? Was it fused finally?
I talked about with him getting a CT scan, and he's doing so well, and his, there's apparent arthrodesis on the radiographs. I don't know that it would change anything that we would do. Maybe he could modify his activity. But I think with the combination of some select biologics, perhaps the Forteo helped us as well. It seems like he had healed. I do not routinely get CT scans. I think, a CT scan has real risk, particularly in younger patients. I forget the exact statistic, but there's a real radiation exposure risk, and I wouldn't want one if I was doing well clinically. But I don't know. I mean, I'm open to the wisdom of the crowd here. Maybe I should be getting them.
No, just for a reason, whether it was the biomechanics it infused, if it's not necessary from a clinical point of view, if it has no consequences, you don't need to, in my opinion.
Yeah.
I love that you showed the L1 pelvic angle stuff. I think I spent obviously a lot of the last 2 years learning from Mike, but ultimately I think he's right about a lot of things and is really good. And I think this answers kind of another question. It's another kind of tool to have when you're evaluating where you're putting your construct. Doesn't mean it's always the end all be all, but I think it's actually something that'll probably, once it's out there, will stick around, and for me has been very, very helpful.
Yeah, I agree. Mike and Jeff are two of the smartest people I know, and then they got together and did this. I'm going to listen to them for sure. All right, so case 4 here. This is a 65-year-old, multiple prior surgeries, bad T-score for reasons that I was sort of unaware of. Very high pelvic incidence, very bad lumbar lordosis, very, very high pelvic tilt. So his pelvic tilt is so high that orthopedic surgeons, here will recognize he looks like he's about to dislocate anteriorly, which is a whole nother topic in and of it to itself. But, this is a case, looking at the CT scan, I see this vacuum disc phenomenon. He is solidly arthrodesed to L5 from L2 and has wide laminectomy from L3 to the maybe proximal third of L5. He is not fused at L5S1. Obviously, the driver of some of his deformity are these compression deformities of L5 related to his poor bone quality. When I see this vacuum disc phenomenon, I view that as a glimmer of hope. For me, again, this case, we sort of like the previous cases, we started in the back, removed the rods, posterior column osteotomy, large. This case, I think it was a 25 or 30 degree case, I can't remember. And here you go, Matt. Here's your post-op ALIF Scully X-ray showing a significant correction in his lumbar lordosis, some correction in his pelvic tilt. His SVA is better. But I would say, I looked at this X-ray and said, this is not enough. And so while I do not like I try to avoid doing 3-column osteotomies. When the patient needs it, it is still the right thing to do. And so, we took him back for stage 2. I will say this, I think it's controversial where we did the pedicle subtraction osteotomy. For me, and I've heard other people say this, prior TLIF at that level is a relative contraindication to a PSO. There's nothing that I worry more about than ventral epidural scarring, and I'd love to hear maybe some of the more senior surgeons on this call tell me how to deal with that. But we did an L2 PSO because of the relative lack of epidural scarring at that level versus the levels below. And achieved a nice correction. Again, some undercorrection in his pelvic tilt, although with a PI of 79, if you look back at Jeff and Mike's paper, you'll see that's not normal, but it's more normal for a pelvic incidence that high. we used quad rods. I use these satellite sort of rod configuration. I really like a nested rod, but I also have some difficulty getting those intermediate screws deep enough and the screws above and below high enough without those rods hitting one another. Sort of pearl I would have is, for me, if I can do the PSO, is, say you're faced between an L3 or an L4 PSO. I try to do my PSOs lower and lower for a number of reasons that we can talk about. But if faced between some relative virgin epidural space versus revision space, I would encourage others to take the more virgin path, because otherwise you'll end up using a lot of these products and sort of having a nightmare on your hands. But open to thoughts on this case. Matt, L4, is that where you would have done this PSO? L3, what would you have done?
I mean, I guess ideally, yes, but I mean, boy, that's a good result. Yeah, I mean, I would 3 or 4 lower, obviously, but I don't know. That looks pretty good.
I think, for me, I will spend hours on SurgiMap, sort of, geeking out on different osteotomy levels and sort of the ramifications of doing it at one level versus the other. But the epidural scarring at L3 for me was enough to scare me away. Ali or Coy, am I being a wimp? Should I have just gone for it at L3? What would you have done?
I don't know. I'm not sure that, I think you have to do what's in your hands, what you feel is most comfortable with. The scarring thing it's a pain in the butt. It increases the chance of CSF leak, nerve root injury. But yeah, I mean, Matt also has a good point. I think traditionally you get more bang for your buck down below. An L2 PSO is certainly not very common. It looks like here you contoured the rods nicely so that you don't have necessarily an angular kind of deformation of the rod, which I think, that's one of the issues. But it, the lordosis looks very harmonious, and see how he does, I guess, down the road. But that's a really nice result. Mike Selby, did you want to say something? I saw you pop on.
Hey, Ali. Yeah, I mean, I've had the same experience as Byron with doing this sort of, trying to do a PSO around the TLIF is pretty challenging. And I probably would have gone the way you went in this case. I would have done exactly the same thing. The only difference may be at L2, when I've done this previously, I've done more of a corner osteotomy, which is a little more dangerous than a PSO, but going up into the disc and really sliding that corner back down, I find gives you an extra 5 degrees maybe over what the PSO might. That might have been my only change. I don't know if others are familiar with the corner osteotomy or do them regularly. I've started doing them a bit more just to get these sort of hyperacute corrections above prior flat fusions.
Great. So Mike, you're talking about taking the corner of the inferior vertebra as well. I'm not
No,
familiar.
so the corner osteotomy is essentially an extended PSO going into the disc, but your cut through the pedicle inferiorly is really angled. So you actually need quite a wide laminectomy caudally, and then you're angling that osteotome or whatever tool you use, your ultrasonic bone scalpel, right up into the disc. And then you rely on having a little bit of mobility in the disc in front. So it can't be done in completely ankylosed spines. So you're doing it at your cranial level, and then everything sort of rolls back. It's a nice technique. I reckon it was published in European Spine Journal maybe 5 years ago, first time I saw it anyway. But they did report a slightly higher complication rate than regular PSOs, although you do get a little bit more angular correction. I'll have to put it up on the socials with some diagrams.
Yeah, I'd like to see that. That'd be great. Yeah. So next case. This is a 68-year-old female, surgery done, one surgery actually done in East Tennessee with, again, classic sort of flat back complaints. And I think this is a case, where I get the CT scan and sort of, recognize that there is no other option here, right? This patient's solidly fused. She had robust posterior lateral fusion. You can see it on her AP Scoliosis X-ray here. And it was, I think this is a case for me in my hands where a pedicle subtraction osteotomy is the right answer. In this case, I think we did it at L3 PSO. And she had obviously this combined coronal sagittal deformity. And we had to spend some time on the surgeon map, sort of figuring out, how to properly take that asymmetric cut. And I think got a nice result with her as well. Anybody do this differently? This one's pretty clear in my book. The difficulty, of course, being the asymmetric portion of this. I find these to be particularly challenging cases.
Byron, it's impressive images and nice case. What I see on the X-ray AP is you're bracing your patients post-operative. Will you continue with bracing? Do you think the patient will be compliant and wear the brace at home?
The brace is for me, not them. I think it's just peace of mind. And I'm relatively inconsistent on bracing. Sometimes I brace people. I try to brace. I do brace my 3-column osteotomies. But I think there's absolutely no evidence to support that decision. It's entirely it's entirely based on my own sort of fear. But
yes, I do the same. So there's no algorithm in my practice. I do it individually. Some patients, I think they have a profit of a brace. I remind them to act a little bit more cautious. And some patients, skinny patients, I'm aware of decubital problems. I think it's important to make individual therapy post-op as well, because in intraoperative it's very individual and very patient-specific, and post-op it's the same for me. And some get braces from me too.
Well, Byron, I think these were great cases. I think on behalf of the team, I want to thank you for spending an hour of your evening teaching us. I personally took a lot away from the the hyperlordotic ALIF, and was very impressed by the correction that you got there. So thanks again for spending the time. And like I mentioned, this will be posted on YouTube within the week, where we get tons of viewership, and feel free to show it across your platforms. I'll ask Dr. Galgano to introduce the topic for next week, but thanks so much everyone for being here.
Yeah, so next week we're going to have one of my previous co-residents from upstate. His name is Hoon Choi. He's fantastic. He trained at Wisconsin for fellowship, and then he just took a position at the Cleveland Clinic in Fort Lauderdale, and he's really a robotic extraordinaire. So he's going to be talking to us about robotics and spine surgery, essentially from the cervical region all the way down to the pelvis. I've heard him give this talk before. It's very interactive. It's fantastic, and I think you guys are going to love it.
All right. Well, with that, everyone have a great evening, and we'll see you next week. Thanks again, Byron.
Thanks, guys. Good night.